Si tira su bevendo come se fosse ancora il tempo. Non cerca nuovo, ormai ha smesso. Se resta solo fa lo stesso. Voleva un figlio oppure un sogno che la facesse stare donna. Stronzo tu che pensi Troia quando lei gira in minigonna. Sola, donna sola, donna sola.
Ragazzi, are you ready for the next episode? See you soon. bello. Sebino bello. What are you doing? Sebino bello. Hello, 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 hello.
Capito.
Ma this was very strange. Zoom was changing a little bit the situation here. So I was in a room which nothing happened. So I said, "Okay, Sebino, what are you doing?"
No, it was sweet. Don't worry, it was sweet.
Yeah, it was sweet. Yeah. Okay, ragazzi, how are you? How are you? Sebino, ciao. So, finally, the happy hour is here.
What do you mean finally? We're here every Sunday.
No, but I get the impression that I didn't see you for months. Yeah.
Yes, because the last weekend we didn't meet. That's why.
Yeah, exactly. Yeah.
You only missed Emilios? You didn't miss me and Isa?
No, come on, come on. Costantino and Nisa, you are my brother and sister.
Oh.
Allora. What are you
Hungary,
about?
Hungary, Uzbekistan, France, Poland, Germany, Turkey, French, Romania, Cyprus, Peru, Argentina. Come on, Latin America. Give us more Latin America.
Yes.
Guys, hello from everywhere, wherever you are. So,
Great.
how do you feel, my friends? Are you ready?
Yeah. Yes, we are fresh and energetic. Yes.
That's fantastic.
What is the question of the week? Yes. Did you experience recurrency when removing a nevus for cosmetic reasons? It could happen, It could happen.
It will happen.
Yeah, don't you think that this is happening more frequently when the dermal nevus is more pigmented, is still pigmented, and then you leave a base? Yeah, of course. Yes, and sometimes are definitely the winners. Yeah, with only 9, no. Yeah. Yes, it happens. So in order to feel a little bit more relaxed when it happens, then let's review this paper, my guys, my friends. The paper I want to share with you is this one.
Wait a moment. But Sebastiano wants to play the jingle.
I forgot.
Bravo. You see, Sebastiano? You see?
Sebbi, I'm very sorry. No. That's what I wanted to tell you about the paper that I wanted to share with you is this one, recurrent melanocytic nevi and melanoma in dermoscopy, results of a multi-center study of the International Dermoscopy Society. Sebbi, can you organize a poll right now? So organize a poll. Are you member of the International Dermoscopy Society? Yes, no, I don't know.
Okay, 1 minute.
Yes, no, I don't know. Yeah.
Sometimes it's not an answer, eh? Here.
Sometimes it's not an answer. Okay, so this is a very nice paper just focusing on this particular topic, which was, by the way, published already a few years ago. Let me tell you, 10 years ago already. Impressive. And this paper was based on a very nice paper, a series of 98 recurrent nevi and 62 recurrent melanomas. Yeah, so it's quite a good paper to draw significant conclusions. And what are the significant conclusions? First of all, from a morphologic point of view, the difference is very clear cut. Yeah. So in melanoma, the pigmentation, the residual, the recurrency is showing up as a pigmentation which is going beyond the scar's age. Okay. So by far, this is the most significant morphologic finding in recurrent melanoma, while in recurrent nevi, the most striking morphology is this streak-like appearance of a symmetric recurrency within the scar. And I will show you a few examples. But what is really interesting is the timing, the time interval, which was also significantly different between nevi and melanoma. And paradoxically, we expect that nevi can recur earlier, while it's the opposite. Melanomas can recur earlier, while it's the opposite. So basically, longer time interval of recurrence is seen mainly in melanoma, while nevi, if they have to recur, they recur quite soon after the surgical operation. Okay. So this is the main findings. I want to show you also something else from this paper. This is a nice table concerning the locations. And as you can see here, melanoma usually, when recurring, is recurring more easily, more frequently on the face, head, neck region, followed by lower extremity. I don't know why. While the majority of nevi are recurring from the trunk.
Possibly because face is lentigo maligna. Lentigo maligna
Yes.
is
No. That's of course understandable. I don't know why lower extremities is also a place where melanoma is recurring frequently, probably for the same reason, because for the lower leg, maybe the margins are more closer, yeah, because of the anatomic location. So let me show you a few examples. This is, this is what you can see in recurrent nevi. In A, you see the typical pattern of this streak-like border of a symmetric recurrent pigmentation. Yeah, and also you can see the same pattern in B, but you can see that the pigmentation is just within, lying within the scar. Okay, it's not going beyond the scar, and this is also visible in C and in D. Okay, while in melanoma, as you can see here, you have first of all a very let's say atypical pigmentation. It's not this kind of streak-like symmetric pigmentation that we saw before, but it's a kind of residual melanoma which is proliferating again, and with the same patterns of the primary melanoma that we excised a few months or years ago. Okay. So on the at the bottom line, this is basically what we can see in morphologically, more significantly associated with recurrent nevi, radial lines, symmetry, and centrifugal growth pattern, while in recurrent melanoma, you see circles if you are on the face, of course, eccentric hyperpigmentation at the periphery, chaotic growth pattern, non-continuous growth pattern, pigmentation beyond the scar's age. The last one is the most significant finding. Bene, that's it, my friends.
Nice. By the way, this pattern that was first described back then.
Okay, sorry, Emilio. This is the poll. So, are you a member of the IDS? Yes, no. Yeah, I don't know. It's also nice, So maybe they don't know.
Well, I have a feeling that our audience is a bit biased.
Yeah.
Okay, yes,
Wow.
70%, no, 30%.
No, 30%. That's
Oh
too
my God,
much.
Emilio, say something. Say something.
No, I cannot. We stop the episode now. As a protest.
So the underline why this 30% should become a member of the IDS.
I mean, come on. No, I don't have to underline why. They know why they have to become members of
No,
the
they don't know, because otherwise they were not they were not saying no. Come on, say it. I mean, you don't pay anything first. This is the most important thing.
I mean, always when you want to say something good about the IDS or the DPC, the first thing you say is pay anything.
Free of charge. Free of charge. Okay, you don't pay anything. You just go on the website of the idea, or the homepage of the IDS, and then you register. And of course, you get a lot of benefits. And above all, the most important benefit is that you become a member of a beautiful family. This is the most...
Exactly.
Yeah, don't you think so? This is the most important recap, right?
So the poll was repeated, and now we are at 80% members, 20 no. Continue like this for, I mean, do it, because they can, in the meanwhile, you can register. It's very fast. You can just visit the website, you give your data.
I sent the link for registering in the chat.
Yeah,
Yes.
Konstantinos.
Yes, it could be that until the end of the episode, we can reach 99% of members.
Yes, we have to make
Hopefully.
the poll at the end. Yeah.
Exactly. By the way, one of the things that I don't know how many people know it, but I guess that they will be very interested, is that once you become a member, you also get access to the members area of the website, in which there is a lot of educational material, very, very nice webcasts, mainly in English, but now not anymore only in English, also in other languages. Very nice, short 5 to 7 minutes videos on various topics, which are enriched every month. So every month we have a new one added to the very long list. Now we have more than 350 webcasts published online. And in addition to this, since you asked me to say why, I start speaking.
Yes.
Another thing is that this year, in 6 months from now, what's happening in 6 months from now, my friends? You know,
Argentina.
So we have finally, after 2018, 6 years after this, we will meet again the global family all together for the World Congress of Dermoscopy in Argentina in October. And of course, if you are members of the IDS, you have a reduced fee. Again, we go back to money.
So no free of charge. It's not free of charge, right?
It's not free of charge.
Come on. This is a pity. Yeah. Okay. Well, wonderful. We have a couple of questions. Do the margins of excision come into play? Yes, of course. Yeah, of course. That's why a face, head, neck is the most frequent site of melanoma recurrency, because of course the margins on the face are sometimes a little bit more limited, and also because in my view on the face there is another actor playing a role, which is the melanoma field cancerization, So I strongly believe that there is something very similar to what is the concept of field cancerization occurring in squamous cell carcinoma and actinic keratosis.
We
Good.
already have the first proposed quote of the day. Beyond the edge is melanoma revenge.
Oh,
Oh,
very artistic. This is very
Inga, this
artistic.
is beautiful.
Poetic, very
Wow.
poetic, very poetic.
Wow.
By the way-
Andrea, by the
Great.
way, Andrea is saying that I'm waiting to be accepted at IDS.
You will.
Yeah.
Don't worry.
Tomorrow morning.
Okay, good.
I was about to say before that in this paper that you showed, one of the nice things that was then firstly described, and then it appeared to be very, very correct observation, was this radial pattern that recurrent nevi acquire. So when they recur, they look a lot like spits somehow. They have these streaks, these peripheral streaks. And that's quite typical for a recurrent nevus.
Yes, but now you are saying something a little bit wrong, because
Really?
I'm going to show you a very old paper of mine,
Yeah.
in which, but this was published, I suppose, in the Italian journal. That's why you don't find it. Yeah, no, I cannot.
You mean you described it earlier? That's what you wanted to say.
Yes, exactly.
Okay, sorry.
Yes, no, I don't see it. I cannot find it. No, and but this is also true that who was publishing first this pattern of recurrent neva? Ash Margub.
Yeah. There are many occasions when I cannot recall anymore who was the first to publish something, because often we discuss so much about new ideas and so on. At some point they get published, but I cannot anymore recall who was the first to publish this and that. Anyhow, that was a very successful sign. That was my point. It was not who who described it first, but they really look like reed nevi when they recur, which is not the case for recurrent melanoma.
No.
Not at all the case for recurrent melanoma. And then the other thing that I wanted to ask you in general is the following. In melanoma, in this study that you showed, the entire community was able to recruit 60 recurrent melanomas. So my question is, does it happen often to you? Do you consider this a frequent problem, the local recurrence of melanoma?
No, it's not a common finding. Definitely.
Except of lentigo maligna, of course.
Lentigo maligna is the most frequent, yeah, definitely.
Acral melanoma.
Acral melanoma as well, yeah. But I get, of course, I'm biased by the fact that, I receive as a second opinion cases from other colleagues getting this experience, and that's why my, let's say, my thinking on the topic is it's not so rare. It can happen. It can happen time to time to everybody.
Okay. Yeah. One question. So have you ever seen melanoma in situ with short margins recurring?
Lentigo maligna, many times.
No.
Yeah. Well, I saw many recurrent melanomas that were first diagnosed as dysplastic nevus. Okay. And therefore they were not re-excised.
But not many. You just
not many.
Peculiar cases, but are they many?
No, not many. But sometimes it happens,
Why, if I asked you how many times did you see a recurrent BCC or squamous cell carcinoma, you would say every day.
Yeah, almost every day. Yeah.
So, of course, this is to a large extent related to the fact that melanomas are treated with wide excisions, while In basal and squamous cell, we are much more relaxed with wide excisions. When the margins are fine, then, I mean, we rarely perform additional wide excisions, while in melanoma, we do it always. That might be part of the explanation. But yeah, in general, local recurrence is not, I mean, that I'm afraid when we're speaking about a melanoma.
Pascal is asking, how can a nevus reappear when the previous excision was histologically complete? No, this is not the case. As a rule, a nevus can recur only if it was let's say, excised incompletely. Otherwise, it's not going to recur. Good. Emilio, do you have cases for us?
No.
No? Okay.
Yes, I do. Yes, I do. But my cases are not related to melanoma, so we will change a little bit the topic. That's why before this, let's take also the nice question by Oli. What do you think about doing wise margin approach for melanoma in situ in face area? And what margin should we use? I guess that wise margin, I guess that only means this idea of directly. Huh?
The John Pauli concept, which was really
yes,
beautifully
John is working on a lot. Directly excising from the first time tumor with almost 5 millimeter margins, so that you don't have to re-excise, based on the fact that we can accurately predict with dermoscopy if it's a in situ melanoma, or if not in situ, at least very, 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 very early invasive. So, do you want to comment on this? This approach?
Well, yeah. Say, Costa.
I personally apply it to all my patients.
Really?
Lentigo maligna is maybe an exception. I'm not entirely sure, because we can also use adjuvant mode. It's a cosmetically sensitive area, so it's a different concept. But on superficial spreading melanoma, absolutely, this is the way I approach my patients personally.
So what is your way?
So directly, if I believe, and I think that we can accurately predict right now if it's a melanoma in situ or a very early invasive melanoma, I go directly with 5 millimeter margins and do the patient in one stage.
Yeah. Okay.
So you do it in all the cases that you suspect of a melanoma in situ?
Yes.
Yeah, I understand this, but it's just so. And then, if eventually the report comes back as melanoma 0.3,
it's the same thing. I already have the margins.
Yeah. No, I understand. I understand what you say. You can do this, by the way, only if you have a small, so you can control the entire process. You know what I mean? So if you yourself can control the entire process, meaning from the diagnosis until the end, the excision and so on. But if you work with several doctors, I mean, telling everybody, okay, go with 5 millimeter margin, not sure, because I mean, then it could be that you are excising a seborrheic keratosis with 5 millimeter, a typical nevus with 5 millimeter.
I'm talking about my patients that I operate on and I follow up.
Yeah.
In the hospital, the procedure remains the same, because it's impossible to control what other people are doing.
So, but if you have an excision of a melanoma with 0.3 centimeters already done, so 3 millimeters already done from the initial excision, you don't have your 5, you have 3. Do you always recommend re-excision for these 2 missing millimeters?
Depends on where I'm seeing the patient. If it's my patient and I follow him up, no. If it's a patient in the hospital, because other physicians may see him and they may recommend re-excision in a later stage, and the patient will get confused, and there will be a disruption. I change my policy depending on where I am and who will follow up on the patient.
Guys, let's say so. We don't have to be, let's say, you know what I mean. Of course, there are always exceptions, but in my view, since the re-excision procedure is such a, of course, it's an easy stuff. So it's nice to make a battle against unuseful sentinel node biopsies. It's nice to make battles against all the things we do for nothing. But for this particular stuff, it's better to be a little bit more, let's say, stick on the guidelines. You know what I mean? So I don't want to have even not 1% of my patients recurring, not even 1%. I want nobody recurring, and by doing this, the 5mm margins is a nice story. That's why we don't do it as a rule. Of course, there are exceptions, but in general, let's make a biopsy first, and excisional biopsy first, and then re-excision. For the moment, this is the most wise thing to suggest to everybody. Yeah.
You know, the difference is that since Konstantinos is much younger, he's much prone to do revolutionary things in practice. You are becoming conservative slowly.
Yes, yes. But this is a funny thing. You know, the older we are, the more
conservative we become.
Yeah.
I don't think that's the case. The more people you have under your supervision, the more conservative you become. I am responsible for my actions only. If Jeppe does it, everyone else will do it. So I think that this is the crucial difference.
Yeah, exactly. That's a very good point, Konstantinos. Also, that's why, we should be a little bit careful on what we say, even if sometimes what we do is a little bit different. But I think that this discussion is interesting. Of course, I think that in essence we agree. So the point is that also I do not consider the white surgery of melanoma an important thing. So of course we should make sure that we stick to the guidelines. This should be the rule, but I don't think that the most important issue in the evolution of the patient is if you're going to take this 1 centimeter or 2 centimeters, depending on the breast flow, or if a little bit narrower. That doesn't change anything in my view.
Let me just clarify my position so that there is no misunderstanding. I'm only talking about superficial spreading melanoma and melanoma in situ. I'm only applying these cases. So,
by the way, you have an upload, Konstantinos, by Raimonds, who wrote that he's doing the same as you. But Raimonds is also an expert in these things. Another nice comment by Vera is that confocal microscopy before surgery on the face especially sometimes will show that the lesion is bigger than what you thought. That's of course true, especially for lentigo maligna, for lesions on the face, which often go beyond the clinically visible margins. So that's a very nice comment. Of course, if confocal is available. In Sweden, we have national guidelines that do practically the same. Yeah. Wonderful. So where is I understand, Jeppe, that you want to show us exactly. Thank you.
Rudy.
Hi, Rudy. Wonderful. So we should move on. Nisa, Konstantinos, are your cases more related to melanoma or to other things?
Because I guess that everyone would do melanoma, I did only non-melanomas in cancer.
Oh, me too. So Nisa, you go. Where you go now, Nisa?
Should I start?
Yeah.
Yes.
Okay. Can you see my screen?
Yes.
Yeah. Okay. Let's start. So after Jeppe's presentation, it's very easy. My question is, Is this a recurrent nevus or a melanoma?
Beautiful.
Nice. Is there a poll?
We have
Or-
a poll.
Yeah, we have a poll. Sebi,
Let's wait for the poll.
Let's wait
I
for
think
the-
Sebi has gone.
I think everybody will say
Yeah. Poll is up here.
here we are.
So it's very easy. I think
No. It's nice. It's nice. It's a very nice example of what we were speaking about. Yeah.
Yeah.
perfect. The majority got it for sure. Because after JP's presentation, we know that if the pigmentation is on the scar tissue, it's most likely to be a nevus, recurrent nevus. And I'm going to show you the case because this was my case. This is a lesion. The patient was a 28-year-old female, and she said that after with shaving, it starts to bleed. So she said that please remove it. I don't like it. And after removal, you see the recurrent nevus, as I show you, and this was the nevus. So we are sure that this is not a melanoma because I excise it and my pathologist look at it, and I know the previous images and pigmentation recurs on the scar tissue, so we don't have to re-excise it, right?
Yeah.
Sure, of course.
Yeah. Because we are sure that this is a nevus.
Yeah.
So the approach can be like this. If you excise it and if you trust your pathologist and if you know the previous images, you don't need to re-excise the recurrent nevus. You agree, guys?
Absolutely. And this
This was
also
also a
underlines
question.
this also underlines the importance of having an histologic report of the primary lesion, because if you did not have the histologic report of the primary, then everything would be much more complicated.
Yeah.
Yeah. And these are all recurrent nevus because they all developed on the scar tissue, as you can see. This is a melanoma surgery, but during the rotation flaps, there was a nevus here, and it was also a recurrent nevus. And here are some dermatoscopic patterns of recurrent nevus, and Jeppy showed us some very beautiful examples. Generally, the pattern is radial lines. And this is a lesion on the face. We talk about the nevus, especially located on the face, tends to recur because they have generally a dermal component and they are deeper nevus. And if you don't excise it properly, the result will be like this. Now, the other problems, because we have nowadays a lot of cosmetic procedures, laser, radiofrequency, and this patient comes from a beautician, and she wasn't a doctor for sure, and she just applied here 2 cycles of radiofrequency, and after radiofrequency, this is the result. So we don't know what it was. So I think here maybe excision will be a good decision. What do you think, guys, for lesions like that?
It seems to be
You don't
trending.
know the previous one, and the patient comes and there's a recurrency like this. So we don't have a histopathologic report here
That's
because
the
it was
point.
a
That's the
laser
problem.
therapy.
That's the point.
So
you know?
I excised, yeah, and I excised it, and it was a recurrent nevus.
Yeah.
Another procedure, you can see there was a nevus here or melanocytic lesion. We don't know what it is. And laser removal was applied here. And here's the dermatoscopy again. So I again re-excise it, and it was a nevus. But to be on the safe side is always the better one. And another laser therapy, there's a melanocytic lesion, and you can see the pigmentation here again. And this is a tragic case, not so tragic because this is not a melanoma. This is a congenital nevus. And again, a beautician applied an acidic solution over the surface. And you see the recurrence of pigmentation after acidic solution. So nowadays we have a lot of cosmetic procedures, and the ones who perform these therapies are generally not doctors, not physicians. That's the big problem. So if it was a melanoma, for sure, it will be a disaster. And I have again an interesting observation. Maybe you also saw cases like this. There's not a trauma. There's not a laser therapy here. There's not a previous excision, but dermatoscopically, the lesion is looking like a recurrent nevus.
Yeah.
We have radial lines.
No, obviously there was a trauma, not a significant one, but
yeah, perfect, Emilios. And I accessed it, and histopathology report was a traumatized nevus. Sometimes in traumatized nevus, we can see similar pattern radial lines without the prominent white structureless areas. So this was a traumatized nevus. And what do you think for this one? Again, we have some radial lines.
Could be also BCC.
Yeah.
Yeah, perfect, Emilios. Congratulations. This was a BCC. Sometimes BCC can be a mimicker because we have also some radial lines in basal cell carcinoma, especially in the superficial type. And this was a basal cell carcinoma with radial lines. Another problem is with nail matrix nevus, because generally, if you don't perform a matrixectomy and grafting, it recurs. And the recurrence of this nevus is terrible, because this time you have to follow it up in a more challenging way, because the features are very chaotic, and it's really very difficult in these types of nevus. They are all nevus. And here, a melanoma, the patient was operated for a lentigo maligna 10 years ago, and this pigmentation around the scar tissue developed recently. And here's the dermatoscopy. As JP showed us, in especially facial lentigo maligna, we have some circles, follicular obliteration, eccentric structureless areas, and here you can see the recurrence. Again, here we have some circles. And histopathology was lentigo maligna here, recurrence of lentigo maligna. So it involves a huge area, and we performed Aldara for this patient, which has a great result. And 3 years passed, and there's no recurrence after Aldara treatment.
Absolutely.
Again, acral melanoma. This patient was operated in Germany 10 years ago. You can see the scar tissue, and there's a recurrence. Here we have ulceration, but at the periphery, we have also some pigmentation. And I took biopsies from 4 parts, especially at the peripheral part. And it was again a recurrence of a melanoma. And here the invasive part. And this is also a tragic case, because as JP told us, 10 years ago, there was a melanocytic lesion here, and it was excised. And it's very interesting. 10 years later, this nodular melanoma developed here, just beside the scar tissue. You can see the whitish area, which is the scar tissue, and this is a nodular melanoma. And breast of thickness was 2.7 here, and number of mitosis was around 30. So the patient is still young, because she was 55, something like that. But even after 10 years, there can be a recurrence of melanoma, and it can be a very tragic case like this. So these were my cases.
Very good.
Amazing cases.
It's impressive how it can be possible. I also have a case of a very thick melanoma developing after 3-4 years after having removed a very tiny melanoma. This is impressive.
The question is the initial melanoma that was removed, or the lesion, the melanoma that was removed and diagnosed as a dysplastic nevus, in fact, was a very thin or not? It was inside.
Actually, I asked the histopathologic report, and they couldn't bring me the slides. So I just have the paper, and it was reported there a dermal nevus, so not a dysplastic
okay.
nevus. Yeah.
So then
Okay.
it was thick.
So it was a thick melanoma. Because
Mhm.
because what I wanted to comment, I wonder, of course, I don't know. I wonder if we were speaking about a melanoma in situ, that or very early invasive melanoma that was excised, diagnosed as a dysplastic nevus, okay, therefore no re-excision. Would it be reasonable that this melanoma recurs like this after 10 years?
Yeah.
It would be a huge surprise for me.
Very rare, but
Yeah.
it's
For me as well, I was really very surprised.
Yeah.
By the way,
wonderful.
guys, I
By
think
the
that
way, yeah,
we opened a Pandora's box with all this conversation. Look at how many questions. And I
yes,
also
we have a
want to
lot of
comment
questions. Lot of
on
questions.
Nisa.
Yeah.
One of them about imiquimod, how, wait a moment. Sebastian is trying to show us something. Okay.
Yeah.
Sound, Sebastiano, sound.
The sound is not here.
A pity because it looks like an interesting video.
Yeah.
Yes.
Yeah.
Okay. First about imiquimod, how long did you use Aldara in this case?
Actually, we're just 1 month, because there was a severe
The video.
There's something
5 times a
growing
week.
inside.
Yeah, and
What's
we
it?
could.
I think it's a heart. People, we are in love, isn't it? We are very much in love. I can't believe it. We did this. Photo Finder and Dermlight are officially merged and together. Exactly. And why are you into us so much? I'm in love with Dermlight because they made dermoscopy globally accessible. Why do you love Photo Finder? I like it because you care so deeply about the dermoscopy workflow, trichoscopy, AI. You have the full package of the solutions that people need.
Torsten,
Together,
together, we are the one and only Dermoscopy house for you people out there.
But this is an incredible brand new information that Photo Finder and Dermlight joined and became one company. Yeah. So it means that they cover all our needs. Yeah, truly. Okay, Nisa, what did you say?
Imiquimod?
Actually, in the literature, it's advised to apply at least 3 months, 5 times per week, and it should be 3 months. But according to our experience, when there is severe irritation, and in this patient, there was really a terrible irritation, an ulceration, a crusting, and she couldn't tolerate it more than 1 month. And after 1 month, we look for additional 2 weeks for healing. And after healing, there was nothing there. There was nothing there, no pigmentation, everything was perfect. And we applied imiquimod in this patient just 4 weeks. So for me, from my point of view, the answer depends on the inflammation, irritation. If it is very severe, you don't have to continue the treatment until the end of 3 months.
I agree completely. By the way, would you like to answer a few of the questions? For example, there is a recurrent question concerning what's going on if for example, Rami is saying melanoma in situ clear with 3 millimeter histologic margin after primary excision. Would this be sufficient margin, or would you recommend wider local excision? In my view, we have to remember this. The 5 millimeter margin for melanoma in situ is clinical. Okay, so you as a clinician decide that you have to excise the lesion at 5 millimeter, then you do it, and then histologically it comes 3 millimeter. Then it's fine. It's not a problem, because you excised the entire lesion, and your 5 millimeters were, let's say, used in order to be able to excise the lesion entirely. So 3 millimeter then histologically is fine. But in general, if you get 3 millimeter histologic margins with a melanoma in situ, more or less is fine.
Similarly, Dorian asks if you can accept a histologic minimum margin instead of a clinical one, for example, 2 millimeters in histology after clinical excision. That's very, very similar to what Joby was speaking about. So the important thing is to have 5 millimeter clinical margins and not so much how much the tissue will shrink and which will be the histologic margin.
But this is a very common misunderstanding, and I think that we really need to highlight this. The guidelines speak about clinical margins. It's exactly what Zeb is saying. 3 millimeters histopathological margins should suffice for melanoma in situ.
Yeah.
If it's a deep melanoma, it's a different question.
Nisa, how did you decide that it was a nevus before removal at first case?
Because it was my case. I excised it. I know the first dermatoscopy, everything about the lesion. It was very normal dermal nevus located on the leg. The patient was just anxious about while using blade. It's bleeding, and she had a history of melanoma, and she asked me to excise it, and it was excised. And shortly after the excision, 3 months after, that pigmentation developed on the scar tissue.
Wonderful. Mario says that in my experience, recurrent nevi disappear often without re-excision. Do you have the same experience? Well, I think, Mario, that many times what we see as pigmentation on a scar is not, in fact, a recurrent of a nevus, but reactive pigmentation that often appears in dark-skinned individuals on a previous scar. And this is what might disappear for sure. So it might happen that the pigmentation you see, the repigmentation you see, eventually disappears.
If I can add a comment on this, because I saw it on Nisa's case, and I want to comment on this. So oftenly on darker skinned individuals, on melanoma scars, because they are large scars, you will see a slight repigmentation.
Yeah.
Which, I mean, you have clinical histopathological margins clear. You do your re-excision, you know the melanoma is out, but then you will see a slight repigmentation, which is reactive. So you don't need to do any further action.
Especially on the acral side, Konstantinos, especially on the acral side.
Acral, yeah, on the acral, I have to be honest, I will take a biopsy because on acral I'm a little bit more aggressive. But on the back of skin type 4 individuals, I see it, I don't know, maybe 30% of the cases.
Often, yeah. Laser and the
important question. This is an important question. Sorry, guys. What about recurrent nevi after laser ablation? Do you always shave and send benign fibromatous nevi to histology before laser? And my answer is no, I don't do it, because similarly, when I freeze a seborrheic keratosis, and therefore I don't send it for histopathologic confirmation, when I'm sure that I'm treating with a laser or with a coagulation, a dermal nevus, I don't do it as a rule. I do it only when I have a differential diagnosis in my mind. But this is the point. The point is that we have to be completely sure that this is a dermal nevus. Then if you are not going to send it to the pathologist, it's not a big mistake, because it's the same we do when we freeze a seborrheic keratosis.
You know, now you became revolutionary again because I accused you earlier for being too conservative. And you were annoyed. Yeah, okay. But Jerpy, on the other side, I mean, since we are speaking publicly, in general, it's a great idea when you excise nevi to have an histopathologic confirmation in order to avoid problems like we many times discuss, and like the case that Nisa showed, and we all have examples. I mean, you see a recurrence, then if you don't have the history of a previous report, you put yourself into a difficult situation. Of course, it's not going to change anything, but you put yourself in a difficult situation. While if you have your history report, everything is fine and there are no problems. Therefore, as much as possible, it's better. Huh? Let's say so. Do you agree?
You are so wise.
Completely. Absolutely.
You are
That's
so
why he's the
wise.
president.
Oh my God.
Absolutely.
So, what else? That's also important. Alessandra asks, laser on the congenital mole, like the one we saw earlier, does this increase the risk of melanoma? We have to say that according to what we know, we cannot support something like this, that laser on a congenital nevus increases the risk of melanoma. No, we cannot say so.
No
We
way.
have no evidence.
No way. Yeah. How long? Okay. Va bene, va bene, va bene, va bene. Costantino, in the meanwhile, prepare your cases, right?
Is it me or Emilios?
Go, Costas, go.
Okay, wonderful.
No. Before Constantinos, we have Sebastiano. Maybe wants to show us something more or not. I guess.
No. I'm going to show you after Costantino something.
Okay. Constantinos, then go.
Wonderful. So, as I said, I will focus on non-melanoma skin cancer, and I want to speak about recurrence, not only after surgery, but mainly after cryo, because I want to highlight this point. Of course, as Debbie was saying earlier, our sample is extremely biased on all four of us because we're a reference center. So accordingly, most of the things that we get are exaggerated cases, right? So this is not always the case. However, I would like to leave a common note about non-melanoma skin cancers. In my country, and I guess in other countries, non-melanoma skin cancers are usually referred to as epitheliomas in order to highlight the benign nature of the tumors. However, how benign is a tumor that can lead to this or to this? These are all cases that have been priorly treated with cryotherapy or original therapy. And it's truly a pity because with dermoscopy, we can actually select very accurately the lesions that we can do a destructive treatment. These cases are put because they're at exactly the same location and they're the same subtype of a basal cell carcinoma. This one was excised immediately, and the patient did great, of course. This patient was treated with several courses of cryo and ended up like this. And I want to reference this wonderful paper by some people that you may know, that dermoscopy can accurately specify a BCC subtype with a sensitivity and specificity of approximately 82%. But 10 years after, I think that Emilios, we have become even better than that, right?
I think so. And also we can predict additional subtypes, not only the superficial one.
Exactly. So we can actually get to the subtype with a very big accuracy. And for example, this one, Emilios, what subtype is it?
So sorry, Constantinos, I'm checking the questions. What did you say?
I'm so sorry. If you can predict the subtype on this one.
Nodular.
Of course, it's a nodular basal cell carcinoma. We see the blue-gray ovoidness, and most likely it's superficial nodular because we see some leaf-like areas here, but the main subtype is nodular.
But please, let's remind everybody that nodular BCC is low risk.
Low risk, yeah.
Yes.
Low risk, yeah.
Yes, exactly. And we have some features, we're very privileged to have features that have 100% specificity. For example, leaf-like structures, all the brown pigmented structures, especially if they are present on a basal cell carcinoma without additional features, we know it's superficial basal. This is the safest of all to perform topical treatment, as in here. And this beautiful paper I want to bring to your attention. I think that most of us know it, but let's keep in mind those features. Nodular basal cell presents with arborizing vessels, blue-gray ovoidness, ulceration, blue-gray globules. Like this one. Superficial basal, sulfite telangiectasias, multiple erosions, sunny white structures, concentric structures, spoke wheel areas, and leaf-like areas. Safest to perform regional treatments or have short excision margins. But then, like this one. But then we have the two other subtypes, like morpheoform with arborizing vessels and white porcelain-like color, as in this case, or infiltrated basal cells with arborizing vessels and ulceration, like this one. These are the two subtypes that we need to avoid regional treatments. And here is an example of a patient that has basal cell carcinoma. You can see by the elevated border here. Pardon me? Yes.
Yeah, go ahead.
Which had been treated multiple times. Actually, it was excised at first, margins came back positive, and it was then subsequently treated with cryo. And you can see here that we can see the cranium of the patient because this basal cell was not excised correctly. Or we should never forget about squamous cell carcinomas. This is a patient that came to me actually 4 months ago. This was a squamous cell carcinoma, medium differentiation, excised with positive margins, and then cryo. This is the way she came to me, and this is her progression under cemiplimab 4 months afterward.
So nothing. This was just hot water.
Exactly. She has already metastasis, lung metastasis.
Yeah.
Again, a patient with a basosquamous carcinoma. You can see all the scarring from the recurrent cryotherapies and the 3 centimeter infiltration on MRI. And finally, last but not least, nodular lesions that are hypo or amelanotic should always be excised, as in this case, treated 3 times with cryotherapy. Because we suspect it as a basal cell carcinoma. It's a 7 millimeter melanoma with brain metastasis already when it came to me. So just keep in mind that yes, of course, recurrence is an issue. If a lesion does recur and you're not absolutely sure of the diagnosis or you cannot subtype it correctly, do an excision and go for wider margins. Those were my 2 cents for today's episode.
Very good. Very good. Very good.
Wonderful. Fantastic. So I would say, guys, let's do like this. I had several cases, but I will show you just 2, 3 that was in fact given to me by Zoe. In fact, again, I asked her to present herself, but anyhow. So they're just nice and very quick ones. But then the other ones that I had prepared, which anyhow are a little bit different, could go in another episode, if you agree, that we could discuss incomplete excisions. So how we should deal with excisions when margins are very narrow or even involved. And that's also very interesting in my view.
Yeah.
I love it. Next episode.
So let me show you these very nice cases from Zoe very quickly. Okay, so there we go. 8 months after surgical excision of a nodular BCC, recurrence, yes or no? That's the clinical image. And that's dermoscopy, an easy one, I guess. Recurrence, yes or no?
Yes.
Because we can see the ulceration, but we can also see quite in focus vessels, so easy to say that this is recurrence. Excision of a nodular BCC 2 years ago with clear margins, tricky points, hairy area, multiple benign neighboring lesions. That's the close-up clinically. Clinically, I don't think that it's easy to say if there is a recurrence or not. Yeah. I don't know without dermoscopy, so it's the correct answer here. Dermatoscopically, what do you think is the recurrence?
Yeah.
Sure.
100%,
because we can see pigmented structures. And pigmented structures are very strongly suggestive of tumor nests and also very much in focus vessels that help us a lot to recognize that this is recurrence. In contrast, and that's almost the last one. Here you can see again a recurrence of a basal cell carcinoma, and the question here is which is the strong feature suggestive of recurrence in the previous image, that the feature that leaves no doubt about the presence of recurrence. And this is, of course, number 3, the blue-gray dots, is the feature that makes it sure that this is a recurrence of the tumor. In contrast, when we see only vessels, it could be tricky. Vessels of a scar could sometimes be really similar to the vessels of basal cell carcinoma. I just show you one case, the last one. This is the initial tumor that was surgically excised, and then sometime 1 year, in fact, after excision, you have clinically practically nothing. Dermatoscopically, you have this. So
Yeah.
What's the case here? There are some vessels, they are linear, they are somehow arborizing, they are precisely on the scar. Don't you agree? It's tricky to say.
Tricky.
Yeah. Okay. So when we see only vessels, it might be tricky. Of course, we're speaking about a BCC, so nothing is urgent. Even if you follow up, nothing bad will happen. The worst thing is that the recurrence will become more evident, and we will excise it later. So that was it with the nice cases by Zoe, and we leave the other cases for next week. Questions that we did not answer, did you check?
Yeah, there's still a few, but let me show you first.
Yes, show us something so that I check the questions.
Yeah. Let me show you. Let me show you something. Okay. Yes, and please don't forget.
This is Mr. Fisher. Mr. Fisher is a dermatologist.
No.
And has a small practice with 6 So
No, what's going on? What's going on?
Who is Mr. Fisher?
Who is Mr. Fisher? I wanted to say that it was a very nice, advertisement of the Heine One dermatoscope.
Yes, very nice, let me tell you. And also, please remind that finally, at the end of the season, someone could win a Delta 30 Pro. So you have to just answer the question on this website that you can find here. The chance to win the new Heine Delta 3 Pro dermatoscope until May 31st. And the winner will be announced in the Dermoscopy Happy Hour episode number 20.
Also,
I like this video because it highlights something that I believe: shape matters. So, at least for me. I mean, the shape and the size of the dermatoscope matters.
of the dermatoscope.
Definitely.
I have to be honest. For me, it's important. I mean, I have to say.
For me as well. But let us remind people to please send us your cases, because we will devote at least one episode to cases from the audience, probably the last one, so that it will be more entertaining. So please send us your cases at happyhour@gmail.com. Well, or whatever. Sebi, send
Sebi is very quick.
Bravo, Sebastiano.
Oh, Sebby.
Wonderful, wonderful, wonderful.
Wonderful. Elisa comments that in patients treated with Hedgehog pathway inhibitors, it's difficult to discriminate scars from recurrences. Yes, sometimes it might be. Again, also their pigmented structures are very, very important when present, and ulceration is also very important when present. But in case we see only vessels, then of course it might be tricky sometimes.
To be honest, my nightmare is regions that have had radiotherapy.
Radiotherapy.
They have these arborizing vessels, this
Plus ulceration. That's
yes.
the problem. That radiotherapy induces ulceration. That's the most difficult part most difficult thing to assess. Yeah. What else? We sent everything for histology more to protect ourselves from later being sued by a patient who later has a metastatic melanoma with a non-primary blah, blah, blah. She suggests, and fully agree, did the same comment earlier. So if we are sure that the lesion is benign, a benign mole, can we remove it with laser or cauterization or shaving? Jeppy has to answer this question now.
Well, we discussed already the issue. Yeah.
I guess that everyone has a different approach. I never do laser. I always do excision. I always.
Yeah. Well, but I mean, a dermal nevus on the face, it's beautifully treated by radio wave surgery. You know, so you just cut the elevated part of the lesion. It's marvelous. So we can do it easily. Yeah. Anyway.
How about
go, Emilio, go.
Yeah, I was just trying to check a couple of questions that we didn't answer. But since it's about margins, the questions, it will be included in the discussion that we will do in the next episode.
Yeah.
So I think that we can go with the last things we have for today, starting with very nice cases today.
Nails.
I have to tell you, they are always nice, but today they are particularly nice. Starting with the case for Nisa, 73-year-old, presented with here.
Yeah, surprise.
What? Pascal is here.
Yeah, Pascal is here.
Oh, Pascal.
Hey, Pascal.
Oh.
Pascal, show your beautiful face to everybody.
That's the best surprise. Let's see.
Maybe you arrange that.
Yeah.
Here we are.
Hey,
Pascal.
Let's take a screenshot.
Welcome. Pascal, your microphone.
I don't feel very comfortable to present my own cases, but CB insisted, so I will do for this time. So
go.
So
brava.
Yes, let's go.
Thank you so much.
So you launch the slide?
You want me to? Okay, I can do it. Yeah.
Yes,
I can do it. Okay.
It.
Yes.
Okay.
So
go.
So for Nisa, donc this 73-year-old female, no medical history, and she presented with this 5-year history of an asymptomatic large band of longitudinal local xanthonychia with filiform hemorrhages affecting her right second two, treated unsuccessfully as onychomycosis, as often. And this is dermoscopy. So we can see a clue. So is it an onychomatocoma, a SCC, an onychopapilloma, or another diagnosis? And which one?
How about the free edge, Pascal? How about the free edge dermatoscopy?
I don't have it. Sorry. I think the clue is on the plate. You can see some white.
Looks benign. I don't know what looks benign.
I have some white clots.
1, 2, 3, or 4. 1, 2, 3, or 4. Onychomatrichoma, SCC, onychopapilloma, or other.
If you know me, it's always other.
Or other.
Other.
So you can. So it's an
Seborrheic
seborrheic.
keratosis?
Yes, also called
Really?
nail. Yes, really.
Oh,
Yes, it was approved by histological examination, and it is also called nail acanthoma or onychocytic matricoma. And the main clue is the presence of a numerous milia-like cysts.
Wow.
See?
Wow.
You see? Wonderful.
So for Konstantinos,
Hello, Pascal.
hello. A
Retronychia.
teenager boxing has a hobby, and he presented with this long-standing onychodystrophy of the grade 2, which is starting to become a nuisance. So he consulted, and this is the dermatoscopy. So what is your
Retronychia.
Retro.
Retronychia?
Yes.
Retro.
Trauma, retronychia, yeah.
Yeah. So retronychia, due to wearing boxing shoes that are too narrow. So we have a proximal nail plate ingrowing into the proximal nail fold. And we can see very clearly successive nail plates embedded under the proximal part of the previous one, leading to paronychia. We have a nail plate yellowish discoloration, another clue, and uninterrupted nail growth, the third clue for this diagnosis. And for TP, so 79-year-old female, no medical history, and she presented with this onychodystrophy of the middle finger of her dominant hand that has been evolved for approximately 3 years with no clear major trauma. So 2 previous dermatologists have already investigated her with X-ray and mycologic culture with no anomaly. And I made an histomycology, which was in favor of dermatitis onychopathy. This is dermatoscopy of the plate, and there was one a front view for Nisa.
yeah. So this is the free age dermoscopy. So this is my usual answer to the patient. I'm sorry, I cannot do anything for you.
Yes, but it is not my what I did. So is it a dermatitis? Is it onychomycosis? Is it a viral wart, exostosis, or another diagnosis? And which one?
Let's go for other.
SCC?
Other.
SCC.
I go for other.
Squamous cell carcinoma.
Yes,
other is a great choice.
Yes. So well-differentiated SCC. It is a perfect illustration of this great mimicker nail tumor with localized hyperkeratosis with thickened nail bed, raising nail plate from the nail bed, inducing an onycholysis due to an accumulation of parakeratotic material that we can perfectly see.
Yeah.
Wonderful.
This is a perfect case illustrating the risk of a squamous cell carcinoma, which is much higher than melanoma. You know, you can miss a squamous cell much easier than melanoma. Yeah.
Absolutely. While we continue, Konstantinos, please, in the meanwhile, can you please check the quotes, because I cannot do it at this time.
Yes, absolutely.
Yeah.
I think there's just one quote, and it was great.
Okay, yeah. If there's only one, then it's fine.
Yeah,
So,
it was great.
For Emilios.
From Linda.
A 5-year-old boy without any medical history was referred to me for evaluation of this acquired onychodystrophy on his right thumb, present for 3 months. He used to suck
Lichen striatus. Lichen striatus.
I didn't. Neither. He used to suck his steady with his thumb, figure factor, not sure. So another view, dermatoscopy, general view. And the other one, the following, focused on the nail, the onychodystrophy. So
wonderful. Answer already given. By the way, the nail is very similar to the case we saw last week, but there is an additional thing here, very nicely highlighted by you.
The other, of course.
Other.
As Nisa, I guess, It is an striatus, and the main clue is the linear eruption of pink keratotic papules next to nail involvement. You can perfectly see them. And the onychos, next slide, please.
The next slide is the best thing of all. Yeah. No, the next.
And we see the lateral onychodystrophy composed of longitudinal region, fissuring, onychorexis splitting, hyperkeratosis, leuconychia, blah, 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 blah. And
Blah, blah, blah.
blah, blah, blah. And,
look what's coming. Look what's coming.
So original aspect, 3 months evolution, and spontaneous and complete regression is a follow-up of 1 year. So
you see,
that's the best. Yeah.
Impressive. Yeah, nice, great cases as always.
Fantastic, fantastic, fantastic. Thank you so much.
And the last one for Sebi.
Yeah.
Yes. So just dermatoscopic challenge.
Myxoid cyst.
Yes. Neither. One before what? This is the dermatoscopic view before what? And the next slide after what?
Myxoid cyst.
Yeah.
So, yes. So
myxoid.
So
yes.
So before puncture, this is the typical aspect with the vascular pattern mimicking BCC due to compression of the overlying dermis. And after puncture ring, the next slide, we can see the yellow hemorrhagic puddle corresponding to viscous gelatinous fluid. That's it.
Wow.
Bravo.
Thank you.
Bravo.
So,
You're welcome.
do you agree that I thought when I said that the cases of today are particularly nice? They were really wonderful.
Amazing.
Amazing.
Great.
She's always amazing.
We have a question for you, Pascal, from the audience.
Yes.
You see, the question is, what kind of adapter do you use in order to make photos from the Dermatoscope Heine Delta 20?
Dermlight 10 photo.
Dermlight photo.
Yes, of course. I have a special just to take biopsy photo. Dermatoscopy photo. Sorry.
Yeah. So, but there are since the question.
Yes, but you know I don't think it's the most important is to have time to build your photo. You know, to improve your photo. That's what I do.
Absolutely. But since the question was about the Heine handheld dermatoscope, of course there are adapters that you can adjust to.
Yes, but I have no adapter. I have just a photo.
Yeah.
Je trouve pas mes mots. Sorry, I don't find my word. But
no, but definitely
dermatoscopy.
Dermlight photo is a great
yes, the
tool. Yeah. Wonderful. Thank you, Pascal. Thank you so much.
Pascal, thank you so much. Not only for today, for every weekend that you are, for every Sunday.
Great pleasure to thank you all for all the work you do to improve our dermatoscopy. So it's just it's normal for me. Thank you.
Take care. Bye.
Bye.
And there is a very interesting question by Luca, whether confocal microscopy can help in the diagnosis of basal cell carcinoma recurrence when there are only vessels on dermoscopy. And what I can tell you is that it's dependent on the histopathology subtype. So if we're talking about a nodular basal cell, absolutely. But if you're talking about deep penetrating basal cells, for example, a recurrence of a micronodular or an morpheoform or an ulcerative basal cell, it can be possible that you will miss it because the depth of penetration of confocal microscopy is 250 nanometers, whereas these basal cells can reach up to 750, 800 nanometers.
Wonderful.
The best way is, as Emilio's recommended, follow-up is a good way, I think, for these cases.
I like to say that a recurrence of the BCC is not the end of the world.
Yeah, we can survive, right?
Yes, yes.
Yeah.
I found 3 quotes. I don't know if you identified more than 3.
No, I sent you the 3 on the text on WhatsApp. Those are the 3 that I found.
Okay.
But there are several questions regarding what Jeppy said about winning the Heine, the
Dermatoscopy.
Oh,
Delta One. If you could repeat what you said, and if we could put the link for them to answer the question.
okay, I will put the link. I will put the link.
Yes.
To
Okay.
available for everybody.
Excellent.
And for us also.
Yes.
Are we ready for the Kahoot?
Yes.
Yay!
Let me make a declaration. The Kahoot today is very difficult.
Oh,
Oh.
come on, Emilio, you are so bad.
Oh, come on, I'm not bad. You know that I'm not bad. Just from time to time. Wonderful. Okay.
Now I want to play, but I'm sure that I would lose tremendously to everyone else.
Okay. So loading the pin. Nobody yet. Nobody yet. Why? Cleo. Thank you, Cleo. Thank you, Cleo. Gianpaolo. Chin. You know, slowly arriving one by one in my problematic Kahoot application. Lavinia, Joe, Ashley. Okay, I will not continue like this because everybody knows that all the players will appear as soon as we start. So we start in 3, 2, 1, and
Ignition.
again.
Yeah.
3, 2, 1. Paul first. Quote of the day. So, melanoma coming back leaves the dermatologist insomniac. To go beyond is wrong as to fall short. Beyond the edge is melanoma revenge. And we have a clear winner, which is beyond the edge is melanoma revenge with 74% of the votes. But now I will try to do something. I will stop share. Don't worry, and I will share again in order to share the sound also. Don't worry, everything will be fine.
Okay.
So I think we are fine. Okay.
Yes.
And now we are ready to start with the case number 1. That's the clinical. This is dermatoscopy, not dermoscopy, dermatoscopy.
Easy one.
Okay. And we have the following 6 options. What's that? Solar lentigo, BCC, melanoma, BCC plus solar lentigo, BCC plus melanoma, Bowens. BCC plus melanoma is the correct answer.
Mamma mia. Mamma mia.
Beautiful one.
Can you see the BCC?
Yes.
Can you see the lentigo maligna?
No.
Yes.
Come on.
Yes.
No.
Angulated lines.
3 o'clock.
Right side.
Yeah. Why not?
No, I cannot see it. Come on, I cannot see it.
Here it is.
Beautiful.
So we have Chi, polarized lady, and crazy Spitz, North Pole.
Crazy Spitz.
Yo.
Crazy
Crazy Spitz.
Spitz.
Yeah. Wonderful. That's the next case. I'm a little bit worried because theoretically we should have seen the clinical image first. Now we see directly the dermatoscopic. Okay, it's not a big problem for the moment. So that's the image. That's the close-up. Okay, no problems yet, no problems. And the quiz. What's that? 6 options again. Same options, solar lenticule, BCC melanoma, BCC plus solar, BCC plus melanoma, Bowen. BCC, 8 correct answers. BCC
What?
plus melanoma. Guys, let me tell you, we excised it because we thought it was a melanoma in situ. And the report was melanoma in situ, and there is a tiny BCC in the middle.
But come on.
Come on, that was the report. And then going back, there is a tiny BCC in the upper central part of the lesion.
Yeah.
This is the best. I mean, the best examination tool. This is a term coined by Ralph Brown. Is the retrospectoscope. Yes, you get the pathology report and you go back. Yes, there is a BCC.
This one was impossible. The previous one, in my view, was theoretically feasible.
It was okay, yeah.
Theoretically feasible. Okay.
Good.
So, do you see that BCC and melanoma might collide also? Yes, Mickey, and size matters. Wonderful. We go to the next one, which is the third case, a huge lesion measuring more than 1 millimeter, 1.5, maybe almost 2 millimeters, with this dermatoscopic pattern.
BCC and melanoma collision.
Clear cut.
Plus hemangioma and seborrheic keratosis. It's orange.
Diagnosis: nevus, melanoma, BCC, lichen planus-like keratosis. Okay, 40 correct answers for basal cell carcinoma.
Very good.
What do you want to comment?
No. This was feasible. BCC can be sometimes tricky like this one.
Yeah. It is a little bit LPLK-like, I understand. Yeah. Okay. And we have, yes, polarized lady and chi in the first 3 positions. Next one, bald scalp, a scenario with which I have a particular, affection, as you understand. That's the lesion. This is dermoscopy.
Okay.
And we have to select among the following 6 options: BCC, SCC, melanoma, Merkel cell carcinoma, lymphoma, or inflammatory.
I'm between 2.
"23 correct answers." I told you it's a tough Kahoot today. This is inflammatory, and I don't know, but I have the impression that slowly we might be able to recognize it more and more and more.
Yes.
This shiny and humid clinical surface, and then dermatoscopically this repetitive pattern of very, very small, thin. And
this is in my view, this is called pustular dermatosis of the scalp, but in my view, we have to call it extragenital zone balanitis.
Yes.
Yeah.
Or zone scalpitis.
Yes.
Yeah. Or maybe we can give our name. Why should we use again the name of Professor Zun? He already has a disease.
Yeah.
Yes.
The we need to come up with a combination of your 2 names.
Or the happy hour tumor. maybe.
Huh?
Not humor, the happy hour legion, yeah. And let's see what happened. Chi comes in the first place, yes, and difficult in the third place. And everything will
Vai
depend.
Giampaolo, vai.
By the way, you can see here after 1 week of steroids, the lesion disappeared. And that's the last one.
Okay.
It's really annoying that sometimes the images lose their quality with the zoom because they are really high quality images in reality. Anyhow.
I found a solution on that, Emilios. I found a solution. I'll tell you afterwards.
Wonderful. Very good.
How many BCC are there?
Ma quando sei bella.
How many BCCs?
So it was a BCC based mainly. And the correct answer is 3.
Oh,
3.
3 is the winner. Yeah.
Three.
No. 3. No. It
The
was
winner
2.
was 2. But we had 38 people that voted for 3. Which one is not basal cell?
Top.
Fourth one.
Last
The last one.
The
The
last
last one is SCC.
is squamous cell with white perifollicular circles. Very nice. Very good.
Yeah.
Okay, are you ready?
Yes.
Yes.
Third place goes to Chi.
Bravo.
Place goes to Cam. And first place goes to Difficult.
Yes. He can only be the winner today, you know.
Hi guys, I'm sorry, I am the difficult because Emilio said that when it is difficult, I would like to attend the competition, and I am the difficult. Sorry for that.
Brava, Nisa.
Challenge.
Brava, Nisa.
Speak to us about yourself. Where are you from? Are you a resident?
Brava.
But we can do it with Cam.
Okay, then Cam is the winner. Cam
Cam is the winner.
Cam is the winner then.
Wonderful. Wow, this was a very, an episode which started very slowly, but then it was flourishing, you know?
Yes.
Wow.
From this episode, we could do three extra episodes on March, whatever.
Yeah. Perfetto, ragazzi. Okay.
So we have Cam. We have the winner. It's Doina.
No, Cam is not here.
Tabac. No, in the chat.
Doina Tabacila.
Congratulations.
I don't know. She
Congratulations.
has no camera.
Well, congratulations.
Bravo.
Here you are.
Hello.
Where are you from?
Hi, Doina.
I am from Romania. Thank you very much. Thank you a lot.
Bravo.
Thank you. You are great. Thank you very much.
You are also great, Doina.
I'm very happy. Yes.
Tough,
Thank you.
Congratulations.
Thank you very much. Thank you.
Wonderful.
Okay.
Va bene, ragazzi. So, see you next Sunday, 7 p.m. with a beautiful episode we already know on margins and recurrences. Does it matter always? Yeah.
Wonderful.
Bye, everyone.
Good night.
Bye.
Bye-bye.
Go.